Welcome to episode 6 on hamstring injuries. My name is Stan Conte from Conte Sports Performance and Therapy in Scottsdale, Arizona, along with Nancy Patterson Flynn in St. Louis, Missouri. Before we get started, I want to make a few announcements regarding the future of these webinars. When we started this webinar, it was to provide good educational content to MLB medical departments and provide CEUs during the shutdown. We wanted to provide some kind of normalcy and feeling of community during these uncertain times. What happened was we had more and more medical people in the community contact us and wanted to join. So we added the NCAA medical departments and eventually reached out to high school athletic trainers as well. To our surprise, the group grew over 900 attendees per episode. To date, there are over 1,500 different individuals who have attended the webinars, and many have attended all 5 of the previous episodes. We anticipate only a few of these, but people kept asking us to continue, so we wanted to, and we did. Nancy and I have enjoyed doing this. It's been eye-opening and satisfying to put these on. That all said, we feel like everyone needs a break. We've done 7 episodes, and so after the 7th episode on the hand, wrist, and thumb next week, we're going to take some time off. We anticipate that MLB medical departments will be very busy getting ready for the new spring training, hopefully. After a 3 or 4 week break, we'll start up again doing an episode in a few weeks, doing an episode every few weeks or once a month. That is based on the feedback we get from you in the group polls, which Nancy is going to be putting up right now. We're hoping and anticipate that many of you will get back to work and find a difficult time for these live presentations. We're putting up this poll to see what times might be best for you guys as a group. Many have asked us about demand videos so you can view them at your leisure and still get CEUs. We will continue to do the live presentation for free with CEUs. In fact, we're working on getting evidence-based webinars approved. Anyone who's done this knows that it's an administrative task to get all the information into the BOC. But we'll still try to get the evidence base for the live presentation. Because we want to offer on-demand videos for the CEOs, will increase our time and costs. We're contemplating offering the on-demand option for a nominal fee, which will be much less than any other CEU that you've done, just to cover our costs. We value your feedback and would like you to give opinions on these in the anonymous poll that is on your screen now. I want to stress that the live presentations will continue to be free even with evidence-based CEUs. We will make a decision on whether we can offer the on-demand version for the CEOs after analyzing the poll results. We again appreciate your feedback with these polls and the surveys so we can better tailor these webinars toward what you want. So anybody has any questions about that, you can email us or talk to us, but the polls are the best way to put it together, okay? So let's get to the real stuff here now. Our presenters today are on hamstring injuries. Kelichi Okoraha from Henry Ford Health Systems, Holly Silvers Granelli from Santa Monica, Jacob Sellon from Mayo Clinic is going to be giving our talks today. So we're going to get right to Dr. Okoraha. We found that Dr. Okoraha is a basketball player at Xavier in 2008 and 2009. So we found some highlights. I think he walks on this one, by the way. A little nice shot here.
That's really impressive that you guys found this.
Another little jumper here. But here's the real thing. Here's the real thing. When you get after this play here, he goes one-on-one with Kevin Durant and picks him clean.
Yeah. That was actually his first game in college. So, I had to just let him know, welcome to college.
Okay, that's enough of that. All right. Dr. Okoraha is a orthopedic sports medicine surgeon at Henry Ford. I want to get to that again. Gosh darn it. His education, undergraduate in molecular and cellular biology and a minor in chemistry at Xavier University in Louisiana. His medical school is Harvard University in DC. Orthopedic surgery resident at Henry Ford, and sports medicine fellowship at Rush in Chicago. He's assistant professor at orthopedic surgery at Wayne State University, orthopedic sports medicine surgeon at Henry Ford, serves as an official team physician for the Detroit Pistons, Detroit Lions, Detroit soccer team, Oakland University, Wayne State University, West Bloomfield High School, and a lot of other universities and high school in the Detroit area. He's published over 70 peer-reviewed manuscripts, books, chapters, and abstracts. He's presented over 110 academic sports papers in orthopedic conferences, and currently serves as a reviewer at the prestigious American Journal of Sports Medicine Arthroscopy journals. This is Dr. Okoraha and his two nieces. Doctor, it's all yours.
All right. So first off, I just want to thank Stan and Nancy for inviting me to do this lecture. I know a lot of us have been stuck in the house with quarantine, so these lectures have been really informative and beneficial for the viewers. I know many of the ATs and PTs out here in Michigan have reached out to me and are really interested in this topic, so hopefully everyone's in attendance and will find this beneficial. I got on my Oakland University shirt, so I got to shout out our head AT, Chris Curran, and the group over at OU. So today we'll be discussing hamstring injuries in baseball. The meat of this talk is going to be on our research paper evaluating hamstring injuries in major and minor league. But I think it's important to start with a brief overview of hamstring injuries just to kind of frame that conversation. Okay. So the hamstring complex is made up of three muscles: the semitendinosus, semimembranosus, and the biceps femoris. Now, all the muscles originate from the ischial tuberosity with the exception of the short head of the biceps femoris, which originates on the posterior femur. So the tendons of the biceps femoris and semitendinosus come together as a common tendon and insert on the medial aspect of the hamstring footprint, whereas the semimembranosus inserts slightly laterally and has that deep crescent shape insertion. When looking at the semimembranosus, it originates on the lateral ischial tuberosity, and then it passes deep to the common semitendinosus biceps tendon and becomes the most medial muscle of the hamstring complex. Distally, the semimembranosus has multiple insertions on that posterior medial tibia, as shown here. Now, the semitendinosus traverses the posterior leg overlying the semimembranosus belly. And then distally, it becomes the most distal portion of that pes anserine triad and attaches to the anterior medial tibia. And then the biceps femoris becomes the most lateral muscle in the posterior thigh distally. And then the long head attaches on the lateral fibula head and tibia. And then the short head is similar to the semimembranosus in that it has multiple insertions on that posterior lateral capsule, the fibula head, and the lateral tibia. So the hamstring muscles, with the exception of the short head, traverse both the hip and the knee joint. And that's important because they have a dual function and allow both hip extension and knee flexion. So these actions also predispose the muscles to injuries at both of those locations. So what we see most commonly is in the injury pattern is at the end of swing phase, just before and during heel strike. And at this time, the hamstring is maximum elongation and eccentrically contracts to limit both knee extension and hip flexion through the stance phase. And that's that picture on the right showing it stretched. And so when this usually happens, you have a proximal hamstring avulsion. On the other hand, when you have an intramuscular or muscular tendinous injury, that usually occurs during the takeoff phase of running. So there's multiple risk factors for hamstring injuries which are listed in the table. One being older age, inadequate warm-up. Some of these are things we commonly see. Strength imbalance is very important because there's an interplay between eccentric contraction of the hamstrings and concentric contraction of the quadriceps that can lead to injury in quad dominant athletes. So what we see is that when the hamstring to quad ratio is less than 0.6, athletes are increased risk of injury. Some other factors include poor core stability. So what we know is that the abductor and the core are agonists for the hamstring muscles. And when you have a hamstring injury, you have a shutdown of the core and the abductors. And so when you're rehabbing, if you just focus on hamstring and you forget about the core and the abductors, you have increased incidence of injury, re-injury, sorry. And then other factors, dehydration, and then history of a prior injury is one of the biggest risk factors. And it's postulated that a previous injury leads to higher recurrence because the repetitive scar that forms is stiff and has an altered compliance. So this serves as a stress riser to adjacent normal muscle and lowers that threshold for re-injury in areas adjacent to the scarring. And studies have found that the quality of scar formation and remodeling is the single most important determinant of subsequent muscle function and risk of re-injury. So this is the mechanism of injury you usually see. This is a baseball player batting. See, right when he hits that bag, it has that eccentric contraction and kind of pops his hamstring. So what do we look for on evaluation? We want to know the mechanism of injury. Was it a running event? Was it kicking? Was it jumping? We want to know the location of maximal tenderness, whether it's proximal, the middle muscle belly, or distally. Usually there's some ecchymosis, especially when it's a mid-substance tear. And you want to palpate for any defects in the hamstring. Then you can get into your specific test. You want to test your flexion strength at different angles, 15 degrees, 90 degrees. And then you want to do your special test. This is a special hamstring test shown on the right, where you're having the patient plank and you're holding both the ankles. Then you ask them to flex the unaffected hip. And that affected hip is using the hamstring to really extend that hip and maintain the pelvis. You also want to do a neurovascular check. Commonly in hamstring injuries, you have some stretch of the sciatic nerve, and that can present as peroneal deficits. And then lastly, you want to check your gait. When looking at imaging, we most commonly start with an X-ray, and the X-ray is to identify any bony avulsions from the hamstrings. These are usually typically found in adolescent athletes, and if that is found, you can get a CT to further characterize that bony injury. But most of the time, we're getting an MRI, and this is a T2 coronal MRI. And we're going from the front of the hip to the back of the hip, and we get to the ischial tuberosity right here. What we see is on the right side, you have that normal hamstring black tendon insertion on the ischial tuberosity. On the left side, you see what we call the sickle side, which is fluid surrounding that ischial tuberosity, and you see the black hamstring tendon retracted about 4 centimeters. So this is a pretty big tear that I had about 4 months ago that I did perform an open repair on. On the axle, you can also see that signal posteriorly on the ischial tuberosity. So treatment of hamstring injuries are usually twofold, either conservative management or surgical management. Conservative is usually for the lower grade injuries, the grade 1 injuries, or the middle muscle belly injuries. You really want to start with rest and anti-inflammatories, and that's going to get us through that inflammatory painful stage. After that, we want to progress first to gentle range of motion and strengthening. And then additionally, after you get through that phase, you want to progressively strengthen with eccentric exercises. And also you want to make sure you strengthen your abductor and your core. Injections are a part of conservative management. We usually do them in grade 2 injuries, as we found that grade 1 injuries usually heal without any intervention. And then grade 3 injuries are usually more severe and don't respond to conservative management. So I know we'll be getting into that a little bit later, so I won't steal anybody's thunder on that. And then surgical treatment. The surgical indications are usually when you have 2 or more tendons involved and more than 2 centimeters retracted tear. And usually we repair it if it's proximal. You can do a traditional open technique, or recently we've developed endoscopic, which is minimally invasive using a scope to repair that tendon. Debridement and resections can be performed usually in distal injuries. However, elite athletes usually get a repair in those distal injuries as well. And then reconstruction, if you have a chronic tear that's retracted, you can't get it to the ischial tuberosity, you can augment that tendon with a graft to repair it. So that was kind of a brief overview on hamstring injuries in general. And now I'm going to present our paper on hamstring injury trends in major and minor league baseball. So this is a project I was fortunate enough to be recruited by my partner, Dr. Eric Mackney, and I was able to meet Stan and Chris Camp and Chris Ahmad, Bernard Lee, and really perform this really great paper. So this paper was published last year in OJSM and has been accepted and presented at many national conferences. So as we know, hamstring strains are the most common injury sustained in professional baseball players. However, following a hamstring injury, MLB athletes are subject to prolonged recovery and a really pretty high re-injury rate. The previous study done by Dr. Ahmad in 2011 showed that on average, MLB players miss about 24 days after a hamstring injury, and that the re-injury rate is as high as 20%. And so it's really important to try to identify those factors that predispose to injury and longer recovery in order to really target programs toward injury prevention. So the purpose of our study was to identify current hamstring injury trends in major and minor league baseball players in an effort to understand those factors that influence these injuries. More specifically, we wanted to determine if the incidence of hamstring injuries increased over time, the effect of player and injury characteristics on time out of play, and how grade of injury on MRI correlated to return to play. So to do this, we used the MLB health and injury tracking system to identify all hamstring strains between the 2011 and 2016 seasons. We excluded any injuries occurring in spring training, the postseason, or the off-season. Player and injury characteristics were then extracted from the database and statistical analysis was performed to determine any risk factors. So what do we find? We found that from 2011 to 2016, there was 2,633 hamstring strains of professional baseball players. And we found the ratio of hamstring strains increased in the MLB from a low of 1 injury every 39 in 2011 to 1 injury every 30 games in 2016. And we found that the majority of these injuries occurred at the infielder position, about 40%, and resulted from base running and over 50%. Usually it was commonly to the first base. So when analyzing the number of injuries per month, we found that April and May accounted for 40% of all hamstring injuries and had the highest injury rate compared to the other months. When looking at time missed, we found that the average time missed was about 2 weeks. So overall, over half of hamstring strains in both the major and the minor leagues resulted in more than 7 days loss. Additionally, 16% of MLB and 10% of the minors had more than 30 days lost due to injury. So that's quite significant. And then as we suspected, recurrent injuries were statistically, athletes were found to return in longer time than primary injuries, and that was statistically significant. Lower extremity MRIs of 327 athletes were available for review. And what we found is that a grade 2 injury of the distal biceps femoris was the most common injury. We also found that grade 2 and grade 3 injuries resulted in significantly more time lost compared to grade 1 injuries. So what does this all mean? So our data suggests a higher incidence of hamstring injuries in professional baseball players compared to other sports. When we look at the NBA, it's 0.69 per 1,000 athletic exposures. NFL is 0.77. The previous hamstring paper in MLB was 0.7. And then our study was at 1.09. So the cause of the increased hamstring injury in baseball players is likely due to a number of factors. However, that constant switch from the static standing position to full dynamic running may play a role. So what we found is the majority of the players in our cohort sustained a non-contact hamstring injury while running specifically to first base. Now, interestingly, pitchers were found to have the highest hamstring injury rate, although they don't frequently run to first base. So we broke this down a little bit and we identified that the pitcher starting position wasn't indicated. So the injury could have occurred either from covering first base with fielding or running to first base from a hit. However, when we looked at it, we found no difference between the American League and the National League. And we know that the National League pitchers are the only ones required to bat and run the bases. Therefore, we concluded that in the pitchers, it's likely the majority of these injuries occurred during fielding. So really with those pitchers having a higher injury rate, the pitching population presents an area for future injury prevention programs. Now, the higher recurrence rate that we found suggests that athletes who sustain a hamstring injury are predisposed to a second hamstring injury. And that really has to do with that scar that forms in that adjacent area being an increased stress riser. So, and also we noted that after a recurrent injury, athletes were found to lose more time than a primary injury. So really focused intervention on preventing recurrent hamstring injuries would save baseball teams and players valuable times and efforts. And then lastly, we found that hamstring strains have a propensity for the earlier season. There's multiple factors this could be due, and these are all modifiable factors that we can look to eliminate the injury risk. So some of those are decreased core stability, decreased lower extremity flexibility, lower extremity weakness, and fatigue. So as with any study, our study has some limitations. It is a database study, so the accuracy of our results are dependent on those that inputting the data. Physical exam and surgical procedures were not provided, and we weren't able to comment on those. We calculated the exposure rate indirectly using box scores, and then injuries prior to 2011 were not reported, and so our recurrent injury rate might be lower. So in conclusion, we found that the rate of hamstring strains in professional baseball players has increased over the past 6 years and results in a significant loss of playing time. Our study found that these injuries are affected by injury characteristics being the grade, position played with the pitcher being the most common, running to first base, seasonal timing with early season being the most common, and history of hamstring injury with that high recurrence rate and increased time loss in those players. So this leads us to what do you do with a baseball player with a hamstring injury? So all the previous things we talked about you want to do: detailed history, examination, strength test, imaging plus or minus MRI, although I will say most elite athletes are going to get an MRI, and then treatment, either non-operative or surgical. This table is from a paper evaluating hamstring injuries in NFL players and try to break down time lost based on injury severity. And so what they found is that if it's a single muscle involvement, less than 50%, athletes usually return in less than a week. If there was multiple muscles involved and greater than 50%, it was 1 to 2 weeks. And then any significant retraction or greater than 75% of tendon loss, it's a prolonged recovery with greater than 3 weeks. And then lastly, we want to focus on prevention. All the modifiable factors to prevent hamstring injuries in the first place, and then also to prevent recurrent injuries. And then lastly, I want to go through one of the evolving surgical techniques. So historically, hamstring injuries have been treated surgically with open methods. Now we're transitioning and doing this minimally invasive using the camera and to perform the hamstring repair. So we published our endoscopic proximal hamstring repair when I was at Rush, and this is currently being published in JBJS. So I'll go through this. I will tell you that the age of this patient is not the typical athletic baseball patient, but this case kind of serves as a good reference here. So she was a 47-year-old female distance runner. She had 1 year of right posterior hip buttock pain that responded to conservative management. Then 3 months later, she had tremendous pain during running. It didn't respond to conservative management. Pain was worse with sitting, and she was unable to run. There was no bruising. We did physical exam. She had tenderness at the ischial tuberosity, decreased strength in hip flexion, and significant pain with resisted flexion. X-rays were negative. We performed the MRI, and you'll see the sickle sign that I demonstrated earlier. Right about here. Oh, sorry. Right up there. So it's really a 2 to 3 centimeter retracted tear of the semitendinosus and the biceps femoris. See it again on the axial where you see increased signal posterior to the ischial tuberosity on the right there. And so she was really indicated for endoscopic proximal hamstring repair. Positioning, we want to make sure that we pad all prominent bony areas to reduce the risk of any pressure ulcers. Then the patient is positioned prone on a radiolucent table. We want to have some hip extension and knee flexion to give us a better access there. Portal landmarks, the medial portal is usually just medial to the lateral edge of the ischial tuberosity, and the lateral portal about 4 centimeters laterally. And those are right in the crease. What you'll find is that sciatic nerve is just 1 centimeter lateral to the ischial tuberosity. So what we want to do is come in the medial portal and then identify and come in under visualization with our lateral portal. So when we usually get in, there's usually a lot of bursitis. We'll debride that bursitis down. Shown here using a shaver and electrocautery. And then we really want to identify that tear site. So I kind of have that cartoon drawing on the top left to kind of illustrate where we're at in the hip for those who are not familiar. So this is our tear. The ischial tuberosity is here on the drawing. It's here in the video. And the hamstring tendon is here and it's here. So really we want to get that hamstring tendon back down to bone so it'll heal nicely. So after we identify the tear, we want to identify our sciatic nerve and make sure it's protected throughout the case. So we go laterally. The first nerve we'll probably see is the posterior femoral cutaneous nerve, and then the sciatic nerve lateral to that. See that. Coming up here. So that's the posterior femoral cutaneous nerve there, and then the sciatic nerve is laterally to it. So once we identify that, we know we're safe. We protect that through the remainder of the procedure. So we want to prepare our footprint. We're really going to decorticate that ischial tuberosity to create a nice bleeding bed for that tendon to heal to. And then we usually use 2 suture anchors. Here we're using a 4.5 millimeter PEEK anchor, and that's just a high strength plastic. And those anchors have sutures in it that allow us to pass through the tendon and repair that tendon back down to bone. So here the anchor is going in, sutures are out, and then we pass those sutures through the tendon. Here we are passing them. We usually use at least 2 anchors, so we'll put another anchor immediately. And then we'll also pass those sutures. So this really gives us 4 pairs of sutures we can pass through the hamstring tendon. And then when we tie those back over each other, that's going to repair the hamstring tendon back down to bone. So I'll show here in a second. The sutures all pass through. When we tie, we want to make sure the sutures are, the knee is in 40 to 60 degrees of tension, flexion to reduce that tension. And then we tie and we cut. So there's a repair. We see the tendon is nicely laid down to the bone, and that should heal nicely. We usually place the patients in a brace in 45 degrees of flexion, usually at least for 4 weeks. They're toe touch weight bearing, and then they start physical therapy and progressively straighten the knee and get to normal walking. So that's all I have. I want to thank everybody for your time and your attention, and I can answer any questions.
Okay, that's great. We'll do the question and answers at the end. I want to remind everybody that the Q&A button is on the bottom. Start putting your questions in now. All right, our next speaker is Holly Silvers-Grinelli, a physical therapist and a PhD. She's the owner of Velocity Physical Therapy in Santa Monica. Her education is Rutgers University, a bachelor's, Western University of Health Science, got her master's in PT, and her PhD at University of Delaware in Applied Physiology and Biomechanics. She's a rehab consultant for Major League Soccer, the Toronto soccer team, Seattle Sounders, the Portland Timbers, and the Los Angeles Galaxy. She reviews for over 20 scientific journals and has published numerous peer-reviewed articles and scholarly book chapters. She is a research advisory role in Major League Baseball for hamstring prevention, which she'll be presenting a couple of those studies today that she's done in baseball. She is owner of the Velocity Physical Therapy. She's married to her husband, Dennis, and has two wonderful children. So, Holly, take it away.
Sorry about that, a little early on my share screen, I apologize. Thank you to Stan and Nancy for the invitation. It's a real pleasure to be here and expand my focus outside the role of soccer. We're going to talk, but what's interesting is I've learned so much about this injury, and quite frankly, the biomechanics are quite so similar, and we can kind of share knowledge going forward. My disclosures, I'm just a consultant. I'm the chair for Major League Soccer's MLAR committee. So we'll talk briefly about the epidemiology. There are about 3 million kids participating in baseball in the United States. 25,000 of those are NCAA Division I, II, and III players. Stan published this paper several years ago looking at the epidemiology over 11 seasons, and there was on average about 300 players injured per year with about 640 disabled list days per season. A newer study by Posner about a decade later looked at epidemiology and found that that number was increasing significantly, 439 players per year with an injury rate of 3.61. We're seeing this sort of bimodal distribution, if you will, of the injury rate with these high incidents in April, secondary incidences going forward, but that preseason, sort of early season, which we see ubiquitously across sport, it's kind of what we would expect. But the mean number of days on the DL were about 56 days in this particular study, and they saw this, this study spanned over 4 seasons. They saw a 37% increase in injuries between 2005 and 2008. If we look specifically at epidemiology in high school, baseball injuries rank 5th behind football, wrestling, soccer, and boys basketball. The injury rate is 1.77 in games and 0.87 in practice. We see a similar statistic in NCAA. This was a paper published by Randy Dick in looking at these injury rates stratified by game and practice. Again, NCAA baseball has a relatively low IR, so 11% of the injuries that they reviewed were upper thigh and muscle strains, but 25% of these injuries result in severe injury, meaning they extend over 10 days of time loss. So a significant injury, particularly in the NCAA baseball season, which can be quite short comparatively to the majors. So if we look at NCAA baseball, again, 7th highest hamstring injury rate in any men's sport. So we saw 5th highest in baseball, 7th highest in men's NCAA, highest rates in preseason, very similar to what we saw in high school. Mostly in-season hamstring injury rate in games, so it's 2.41 per 10,000 exposures, nearly double that in preseason. 76% of these are non-contact. Similar to Kelichi's study, looking at base running is the primary mechanism of injury for hamstring injuries with baseball. Close to 17% of these were recurrent injuries. So these are the people we're really concerned about. We have to look at this high reoccurrence rate and what can we do from the athletic training and physical therapy and strength and conditioning side to get this number to be reduced. So there was a study published looking at injury prevention in baseball, kind of across the shift from youth to the pros, and the young players, they're finding the #1 mechanism is primarily overuse driven. 23% of youth, so those were the players between 8 and 18 years of age, reported some history of injury. And this might be due to that real sort of early designation of sport and sport specialization. We've got year-round play in certain communities, certainly here in Southern California. We see that in Florida and Georgia, a lot of showcases in travel ball. We've heard about Kelichi's study, so I won't spend a lot of time there, but the interesting, we're seeing this increase in incidence of hamstring injuries. Again, he found very similar, the mechanism, over 50% of it was base running, primary incidence to the distal biceps femoris, the long head, and mean missed time was 14.5 days in his study. And then Chris Ahmad's study, which we'll spend a little bit more time talking about, was a study looking at minor and major league baseball over the 2011 season. So he looked at HITS data. There were 50 hamstrings reported in MLB that particular season with a mean of 24 days missed. And the minors, there were 218. Incidence rates were identical, actually, between the majors and the minors with a mean of 27 days missed. 2/3 of those resulted in more than 7 days of time loss. 25% of those injuries were greater than 30 days. So that's pretty significant when you're looking at close to a month of time loss. And the history of hamstring in the prior year was 20% in the majors, 8% in the minors. Again, so we're really worried about this reoccurrence. I think from a rehab perspective, we can do better here. So when Chris's data was stratified by month, they looked at the month of May had a statistically higher hamstring injury rate. Perhaps there was a trend for cooler temperatures. So you could see some correlation there with increased hamstring injury, and that may play some role there. The salary costs, when they looked at time lost due to injury, and they parlayed that with the average salary in Major League Baseball. So if you have a high earning player, this will be significantly more, but the average salary loss was about $540,000 per injury in the majors, significantly lower in the minors, $3,000. This probably speaks to the pay differential there, but that's significant when you're kind of, that will resonate certainly with the GMs, and certainly something, you know, from a time loss, we want to get that closer to, you know, a 7-day injury loss. Primary mechanism in this particular study was base running as well. It was a little bit higher. 62% was the primary mechanism for the majors. In the minors, it was even higher, 71%. So I think what's so interesting about the mechanisms in baseball is that it's fairly consistent. Soccer, there's a little bit more disparity in mechanism. So I think there's a real sort of interesting window of opportunity here in terms of prevention intervention. If you look, this is a courtesy of John D'Angelo, the HITS database system, but looking at MLB, but we looked at hamstring injuries across 5 seasons. So this is unpublished data. This article will come out shortly. We're in kind of getting ready for peer review. But there was a mean of 101 hamstring injuries per season with 21.7 days lost in the majors, 483 hamstrings per season with 24. So the time loss is similar between majors and minors, a little more severe in minors. So we're going to talk briefly about my experience in soccer and how this is really relatable across sport, but specific to baseball. So we look at the historical data and prevention. We know hamstring injuries are problematic across sport. So the injury incidence is inordinately high. It's our #1 problem in Major League Soccer and has been consistently and still is. We've been utilizing hamstring injury prevention programs to decrease hamstring injury in the NCAA, MLB, and MLS. And we started utilizing preseason strength assessment, which we'll discuss, and to potentially identify high-risk individuals prospectively. So we look at the epidemiology specific to soccer, very similar to what we see in baseball. It affects 12 to 16% of all injuries in the EPL and Australian football are hamstring related. There's an average of 5 to 6 hamstrings per club per season. So, and the team loss can be upwards of 90 days and about 15 to 21 matches per club per season. The re-injury rate, very similar to baseball, if not slightly higher, depending on the publication, but 12 to 33% of these individuals wind up re-injured. Most of the mechanism occurs whilst running or sprinting. And of course, we have that long eccentric hamstring activation during deceleration, during the extension. 62% of these injuries occur in games, and significantly more of the injuries occur toward the end of both halves. So there may be some fatigue, some neuromuscular fatigue, or some cortical control element here that is worthy of discussion. So this is Josie Altidore. Those of you who follow soccer probably know his name. He's our starting forward during the 2014 World Cup. And he sustained, you'll see him running, he's just speeding down the left flank. He heads the ball to his right and he just reaches, kind of plants left, he's cutting, changing direction, and sustains a grade 2 injury to the long head of his biceps femoris. Unfortunately, it was the game 1 of the World Cup. And was out for the remainder of the tournament. And Josie, unfortunately, this injury has continued to beleaguer him. He's had 4 hamstring injuries on his left side, 3 on his right. Finally, we've got some good analysis on him, and he's been healthy for the last 2 seasons, but certainly that's been an injury that's plagued him. So if we look at the data specific to Major League Soccer, again, our #1 injury, so it's a real thorn in our side, if you will. It's the highest injury rate and time lost due to injury in professional soccer. Significant reoccurrence rate. So for these particular years, the reoccurrence rate was about 14%. This was data over 2 seasons, and combined between hamstring and biceps femoral strains, we had 414 hamstrings reported in 20 clubs. I mean, it's just incredible the number of hamstrings we were seeing. #1 injury in MLS. The mechanism of injury, 45% of the time it's running involved, but you can see for soccer, the picture's a little bit muddier compared to MLB, because we've got tackling, sliding, shooting, passing. There's a little bit, from a mechanism of injury perspective, it's a little bit more complex. But again, we see this sort of bimodal distribution. Again, what we see in soccer and baseball is similar, and our season is quite similar to Major League Baseball season. So preseason starting in late January, we're doing physicals about the 3rd week of January. The season continues to about November, December, depending on how competitively successful you are. And the average return to play for a biceps femoral strain is about 28 days. So we're approaching that month mark. So part of my PhD dissertation, we, as a group, there was a group of us from Santa Monica, the Oslo Sports Traumatology Group, and members of FIFA's FMARC program, collaborated on developing an injury prevention program called the 11+. So this was an injury prevention program designed as a comprehensive dynamic warm-up to be performed prior to training. It was designed to address all soccer-related injuries, so not specific necessarily to hamstring, not specific to ACL. We were addressing everything. The idea was to do it prior to training in a non-fatigue state, about 2 to 3 times per week. So only takes about 15 to 18 minutes to complete. So it's about 30 to 45-minute commitment per week. Again, it was an international group that designed this. We were looking to address all injury, and it's an on-the-field warm-up, and we did that from a compliance perspective, because as we know, compliance is everything. You know, all of the scientists that spend time developing these programs and looking at studying their efficacy, basically it's all for naught if it's not going to be utilized. So from a compliance perspective, we thought of all of the barriers from a time perspective, from an equipment perspective. So we wanted no to little equipment necessary, no costs from a socioeconomic perspective, so it wouldn't be inhibitory. So after we looked at this in Norwegian data, we looked at this in the NCAA. So we contacted every member institution in the Division I and Division II for male soccer, contacted every AD, certified ATC, and head coach. Unfortunately, only got 61 teams, so we only got 16% of teams to participate. We created a testimonial video clip, and those of you who know soccer probably know some of these faces. In the spirit of full disclosure, Tony Miola is my brother-in-law, and that's why I got interested in injury prevention in the first place. But Tony Miola, Bruce Arena, who was the men's national team coach for many years and the coach of LA Galaxy, now coaching at New England Revolution, Ante Razov, who had a prolific career through Chicago Fire and Chivas, as well as the national team, and of course, Landon Donovan. So they discussed how injuries impacted their career, how coaching decisions are altered due to injury, particularly in late season when injuries tend to beleaguer a team, and how playing performance and career longevity are negatively impacted by injury. So each of these athletes, maybe Landon is a bit of an outlier, but they certainly retired due to injury. So the first phase of the study was to look at this data in Norwegian young girls, so between the ages of 13 to 17. And we had interesting data. I'm going to go back just one second. We had a 53% reduction in overuse injury and a 45% reduction in severe injury. And what is so fascinating from a compliance perspective, when we mapped out compliance and injury rate, basically they are inversely correlated. So in these high compliance groups, so those teams using this program at least 2 times per week, they had the lowest incidence rate reported. The teams that were using the 11+ program infrequently, the low compliance groups, had the highest incidence rate. So makes sense. It's completely inversely correlated. The more you use the program, the fewer injuries you will incur, and the fewer injuries from a severity perspective will you incur. So again, we looked at this through the NCAA system. We had 16% teams, 16% of all NCAA men's soccer institutions utilize the 11+ program. And again, we found very similar data. We had 46% reduction in injury and total injuries. We had a 32% reduction in all-time loss. So not only were these soccer players getting injured less frequently, they were getting injured less severely. And if we stratify the data and we look specific to hamstring, what was fascinating is that we found, so if you look, this is sort of mapping every injury. And we had, interestingly, statistical differences in every injury rate that we captured, including ankle, all knee, ACL, and including concussion, interestingly. When we stratified the data specifically for hamstring, we found that there was a 64% reduction in hamstring injury in the intervention group. So those teams, there were only 16 hamstrings reported that particular season compared to 59 in the control group. And we found the very same thing that the Norwegians found in terms of compliance, the statistical difference between high compliance and injury rate. So the programs that were using the 11+ program ubiquitously over 2 times per week, so 2.38 is the magic number, 2.38 doses per season, per week rather, we had this lower rate of injury rate. The low compliance teams using it less than once per week had higher incidence rates. So the other question is, when we're looking for compliance amongst coaches and players, sometimes the appeal of injury prevention doesn't quite compel teams to utilize programs. So we thought, let's look at team performance and see if there's any correlation between team performance and compliance. And we found, yes, statistically, so interesting that the highly compliant teams had statistically more wins, shown in blue, and statistically fewer losses, shown in red, compared to the control group. So this really interesting. In fact, one of our Division II teams went on to win the national championship. Now, I'm not here to say we're making better soccer players or better athletes per se. I just think we're keeping them healthier and more available. So from a coaching perspective, it's a dream because you have your full roster available to you later in the season. And just from an athlete perspective, you're available and you're healthier throughout the competitive season. So we brought this data to Major League Soccer, and we unfortunately only got one team to continue with our intervention, but the Seattle Sounders, and they basically utilized an 11+esque, if you will. We tailored it specific to the pros, and they utilized the program throughout the course of the season. And these are just the map of the utilization. So their utilizations were a little bit heavier up front in the early on in the season. It trailed off as the season continued. But what was interesting is that there were 12 hamstring injuries reported that particular season, with an average time loss of 11.5 days. So we had a 55% reduction in time loss due to injury by virtue of utilizing the program. And when we looked at games lost secondary to posterior thigh strain, specifically to hamstring, prior, so 2012 was historic data. In 2013, there was an average of 1.97 games lost per hamstring injury. There was a 45% reduction. This was the intervention year, 2014, due to using eccentric hamstring utilization. So this was Nordic and Russian interventions. It was a successful campaign as well. They wound up making it to the semifinals. So they were a healthy, successful team. So we've had a number of very well-known athletes succumb to hamstring injuries, and many of these faces probably look slightly familiar to you. But these players presented with chronic repetitive hamstring reoccurrences that prevented them from participating in games. Many of them losing more than 30 days, and quite big competitions. So in Josie's case, Confederations Cup, World Cup, you know, these big tournaments that he was unable to participate in due to chronic hamstring injury. We had one of these individuals who lost 70 days due to injury. So can we mitigate the risk? So we looked at the season-long comparison. We did a dynamometry study, and we looked at 6 muscle groups: hip abduction, adduction, hip extension, hip external rotation, knee extension, and knee flexion. We measured these throughout 3 time points over the season, so preseason, midseason, and postseason, and we tracked changes. So we saw, just left to their own devices, so there was no intervention here, we were just establishing normative means, but hip abduction decreases in midseason, hip external rotation is decreasing over the course of the season as well. We know these are protective muscles with respect to not only the hip joint, but the knee joint as well. So when we looked at this, stratified this data based on limb, we saw that the right lower extremity, and 92% of these individuals were right leg dominant. They showed some greater variability. So preseason shown in blue, red is mid-season, and orange is postseason. So you see these changes, some of which were statistical, between limbs over the course of the season. So the postseason, the right hip extension was significantly decreased, which is a massive indicator of perhaps of hamstring injury risk, and hip external rotation. Hip extension also decreased on the left side. What's really important is when we look at, obviously this has implications for ACL injury, FAI, and hamstring injury risk, but we want to now look at the ratios. And this was really compelling data. So we were looking at 3 different ratios: quad to hamstring ratio, quad to glute, which is shown in red, quad to hamstring is in blue, and AB to abduction shown in yellow. And we saw some really statistical differences. So in the preseason, we saw a 50% discrepancy between quad and gluteal strength. In midseason, that got mitigated slightly. It went down to about 44%. In our postseason analysis, it went back up and exceeded what we were seeing in preseason. And perhaps that's why we're seeing this bimodal distribution, that we've got these larger strength discrepancies in preseason and trailing into the postseason, sort of late season. And this is interesting data. So we wanted to use these normative values and see if we could, we wanted to stratify by type, look at the analysis, and then I'm going to go over one specific case study. So we looked at, this is a study that was done in MLB, so one of the few hamstring intervention studies that's been published to date, but they looked at the effect of eccentric training. This was done at the Kansas City Royals. They had 243 professional baseball players involved, so that was kind of used as a quasi-control. Their intervention group utilized the Nordic eccentric hamstring exercise. There were 65 players involved in the intervention group versus control. So in the intervention group, they had 0 hamstring injuries for that specific season compared to 10 in the control group. And that was a sample size of 34. So it was kind of a self-selected control group. 8 field players and 2 pitchers sustained injuries in the control group, and 70% of the mechanism of injury was due to base running. 90% of these injuries occurred in games. So when compliance was defined as more than 3.5 repetitions of a Nordic hamstring per week. So that was an interesting definition, and we can talk about that on the Q&A, but I thought that was sort of an interesting cutoff point. And also maybe one sort of criticism of the study, it was a self-selected compliance group. So there may have been some motivational bias, selection bias inherent there. So when we look at the MLS, we go back to the MLS data and we look at hamstring injury by type, there were 234 hamstring injuries reported in this specific season that we were doing our monitoring. And when we looked at average days missed stratified by hamstring type, we saw significant decreases in all hamstring types for all of the intervention groups. So all of the teams that were mapping their strength over the course of the season, they had a little bit of a heads up, if you will. They were able to look at the data as it's coming in and know, like, okay, we've got to do some sort of intervention here because we've got this massive discrepancy that we need to address here. So the MLS range was 0 to 136 days lost based on injury, which is really amazing. The mean average was 23.7 days due to hamstring injury loss. Now, these teams encircled in red are the 8 intervention teams. So these were the teams tracking data. So if we compare them to the rest of the group, the intervention group only had 14.6 days lost to hamstring injury compared to nearly double that in the control group, so 27.8 days missed. So again, really effective data, really helping them to make sort of game day changes in their strength and conditioning protocols and their therapeutic interventions to help mitigate the active risk and almost prospectively. So I wanted to discuss, this is an interesting case study. This is Victor Rodriguez. I have permission to present his particular case. He had recurrent hamstring injuries, his left biceps femoris during acceleration, sprinting, and shooting. So his mechanisms were varied. He had a history of 3 injuries. He's an FC Barcelona product. He came through their farm system, and a very gifted player, but was beleaguered by these hamstring injuries. His MRI shows this lateral myofascial border, and he had extensive rehabilitation, intervened with Orthobiologics. He had his orthotics designated or devised rather by a colleague at Real Madrid. He every time was clearing return to play testing, but he would chronically get re-injured. So what were we missing? So we looked at his gait analysis, and what we found, this on the left side of the screen, this was him running at 6 miles per hour, and the 8 on the right side of the screen, it's 8 miles per hour, and you can see his mechanics worsened with speed. So on the 6 mile per hour side, he had some heel strike issues and supination, decreased, he had some hip adduction, a little Trendelenburg. You see this hip internal rotation moment, and at 8 miles per hour, it was significantly worse. So you see this increased rotation through the hip, heel strike and adduction with supination, some knee varus. He was knee varus in stance, but it got pronounced during dynamic movement, and rear foot varus. So we looked at his specific strength ratios, and what was interesting, his ham to quad ratio was 0.79 on the left, his injured side, 0.78 on the right. So we like that ratio to be closer to 0.9. 1-to-1 if we can get it. From left quad to gluteal ratio, significant variability. So he had a 1.72 ratio on the left side, that's his injured side, 1.27 on the right. So what's fascinating there, and maybe oftentimes it's not a hamstring issue per se, there may be this real gluteal insufficiency. So we really need to look at this very methodically and very macro instead of micro. There really is a glute issue here. When we were looking at some of his jumping mechanics, he had significant sort of anterior shear. He's kind of off his heels here. So I described this as decelerating in the sagittal plane. He's unable to maintain his footprint. So there was a real quad insufficiency here, and that was like our major intervention with him, in addition to some of the hamstring stuff. But I think in his prior interventions, they were looking mainly at hamstring and not quad. So we used dynamometry to objectively assess him. We looked at all his biomechanical strength and risk factors and addressed everything. We did an orthotic adjustment as well. It was a very multidisciplinary collaboration. It was so wonderful for him as he wound up returning, was able to play in the final and got MVP. And I'm not taking credit for that per se, but I'm just so happy to see him have a successful return. So let's talk about baseball. Let's get back to baseball. So this was published just fairly recently in December in IJSPT. This was a questionnaire study that we did amongst the Cape Cod and Northwoods leagues over the course of 3 seasons. So we had a validated hamstring questionnaire that was developed by the Oslo Sports Group that we modified for baseball, and we expanded the study from a power analysis perspective so we could get our numbers up. This is a copy of the questionnaire. If anyone's interested in it, I can happily post it. So let's look at some of the responses, some of the results rather. So we had this cohort, so average age between 19 and 23 years of age. Of those players, so basically an high-level NCAA cohort playing summer ball, 23% of them had reported a history of hamstring injury. We had no statistical difference in demographics with the exception of height. Our injured players tended to be slightly shorter compared to the uninjured players. Catchers reported the highest injury history, and that's kind of unique. We haven't seen that in other publications, followed by infielders, outfielders, and pitchers. Pitchers were the only ones that reached statistical significance, though. Overall, 44% of the injuries resulted in greater than 1 week loss from baseball. So, and then 62% of those with bilateral injuries lost greater than 1 week. So those players that had unilateral injury, the statistics were lower. About half of them lost greater than 1 week. And 7 of the 13 players with recurrent injuries lost more than 1 week. So nearly 10% of the player pool had greater than a 4 week time loss due to a hamstring injury. when we look at hamstring reoccurrence, 13 of the players, so 28% reported hamstring reoccurrence in the same lower extremity. Infielders reported the highest re-injury rate, and there was no significant difference, however, having a bilateral or unilateral injury and position and or reoccurrence. When we look at hamstring injury history, this was an interesting kind of statistical way to look at this. So more batted right-handed versus left-handed. However, the highest hamstring injury percentage were those individuals that batted left and threw right. And I know this has been reported elsewhere, but I thought it didn't reach statistical significance, maybe because of our power analysis, but there was no significant relationship between hamstring injury. We saw this trend, but between batting left and throwing right. And we can sort of discuss this because I know Stan was interested in this as well. And we found some significant differences in the HAO score. So this is, again, that tool that we retooled for baseball from the Oslo traumatology group. But what's interesting is all of those individuals who were injured, every screening for every category for previous injury and symptoms, soreness, pain, function, quality of life, their entire score was significantly higher. So the higher score is actually optimal. So the lower you score is less optimal because you've got 100 is actually a perfect score. So we saw statistical differences across the board from injury history compared to those with no injury history. So the next phase of the study, which is pending peer review, we're looking at Major League and Minor League Baseball from an intervention perspective. So this was a 2-year prospective data, and my hat's off, I need to sort of publicly thank Bernard Lee, because he was the one team that sort of allowed us to kind of pursue our intervention with him. We had solicited many clubs during a recruiting session, and both in Florida and Arizona, and we only got one team to sort of take on to our sales pitch. But we utilized the Angels organization, and they were really wonderful partners in that their entire league participated, from fall league, the rookie ball, all the way up to the 40-man roster. And we designed this intervention very similar to sort of the 11 plus to basically mitigate hamstring risk. We had over 191 athletes in the league. We used the HITS data as our skill and league match control. 151 players were in the minors, the majors were 40, and we measured compliance throughout the particular intervention and compared it to the HITS data. So these are some of the exercises that were included in the actual intervention. It's sport specific. It was predicated on some of the earlier interventions we had designed for other sports and that were effective. And we integrated it a little differently because the culture of baseball obviously a little bit different, but into warm-ups and regeneration days, also in strength and conditioning sessions. So this is one of the exercises, obviously a lot of you are familiar, but looking at an eccentric, this is a Russian variant. Just so interestingly, we did a EMG study looking at Nordic versus Russian, and they're both effective, but on the Nordic side, we see a little bit more semitendinosus membranosus buy-in. On the Russian side, because of this dropping forward and pulling back, we see a little bit more biceps fem activation. So when people ask me what's the best hamstring intervention exercise, I like both of these, and I think they should be both used. So let's look at the statistics. So this is the results from the 2014-2015 combined season. This is in the majors. So we had an overall reduction of 32.8% in the 2014 season. In 2015, we had 100% reduction in hamstring strains in the majors. We look at the data stratified for minors, similar profile. We had a 66% reduction in hamstring strains in the minors for the first season. We followed that up for the second season, 48.8% decrease in the hamstring strains for the 2015 season. So interestingly, 5 of the 9 injured players in the 2015 cohort were completely non-compliant. And I think it's an interesting speaking point of the intervention because obviously kind of coupled on top of what we saw on the 11 plus side, we know we are completely contingent upon compliance. If we don't have compliance, this will not be effective. So we looked at time lost due to hamstring injury. We saw a 42.6% decrease in the majors in the first season. Very similar statistics, 42.3% decrease in the 2015 season, in the minors. For the 2015 season, 100% decrease because we had no injuries in the majors, and an 80.6% decrease in time loss in the minors for the second season. So average utilization was 25.3 in the uninjured versus 13.53 in the injured group. So again, when you're utilizing this more prolifically, we have better compliance, injury rates are lower. So the average team utilization, and we coupled this with cost savings. So I know when Chris Ahmad did his projections, obviously the salary differential in the majors and minors is very different, but in the majors, there was about a 1.7 million cost savings per team per year, and the minors, it was approximating 7,000. So why is compliance so challenging? It's like the bane of my existence. I just think as a scientist, you know, we come up with these great programs and they're effective. We scientifically vet them. So why is this translation into practice so difficult? So there's a lot of obstacles. There's these cultural obstacles. But I think when you're looking at developing injury prevention, it's obviously you want to identify the risk, understand the epidemiology and the prevalence, create your intervention, determine the efficacy, modify the intervention, and then from an implementation perspective, you want to scale up and make sure you have good program adoption, really clean fidelity, so the program's being designed as you designed it to be intervened. So we know from an intervention perspective, compliance is inversely correlated to injury rate. So as you increase the utilization of these programs, you'll see a decreased use in injuries when they are scientifically vetted to be effective. High compliance is correlated to decreased time loss due to injury. So we want to ensure that coaches, management, strength and conditioning have their autonomy. We don't want to come across as dictatorial because we have to really engender compatibility, but we also want to diminish complexity because we want to obviously be respectful of all of the knowledge that these particular groups have, but how can we collaborate in a way where we can enhance program compliance and fidelity, and we can mitigate the risk for these athletes going forward. You know, one of the benefits, and people gave us really good feedback about engendering role models. So when we did our 11+ study, by bringing in those 3 former pros and Bruce Arena, that really engendered this really sort of trust, if you will. And that's something I think we can use, but also to talk about the performance enhancement component of it and the winning percentage. I think that's another conversation when we sort of shift the narrative, if you will, to be a little bit more attractive, and we can improve compliance going forward. So future directions, we want to categorize and track injuries through the HITS database, perhaps do a regression analysis, see how we can maybe even finite some of our intervention efforts, utilize perhaps strength and biomechanics assessment to establish the normative values like we did in soccer. We found that inherently helpful, and just athlete compliance and impact the injury prevention and team performance overall. So compliance is paramount. Thank you so much.
Thank you. Thank you. That was great. Listen, a lot of Q&A questions coming in. That's great. We've got tons of questions to ask the speakers so far. Our next speaker is Jacob Sellon. He's going to be talking on orthobiologics for hamstring injuries. He's the assistant to professor at physical medicine and rehab at Mayo Clinic in Rochester. He's a co-chair of Division of Sports Medicine, Department of Orthopedic Surgery. He's the program director of the Sports Medicine Fellowship. His focus is on research is ultrasound imaging and the diagnosis of musculoskeletal disorders, ultrasound-guided procedures, and orthobiologic treatments for musculoskeletal disorders, including PRP. His education is a BS in biology and a minor in kinesiology at Indiana University, Indiana University School of Medicine for his MD. He was a transitional internship at the Naval Medical Center. He's a residency was at physical medicine at Mayo Clinic, and a fellowship in sports medicine at Mayo Clinic in Rochester. Currently, he works with many professional athletes from MLB, NBA, and the Olympics. He's the head team physician at Rochester Community and Technical College. He's a medical co-director at the Mid-City Marathon. He's authored numerous manuscripts and book chapters in a peer-reviewed PM&R, Journal of Ultrasound and Medicine, and Clinical Journal of Sports Medicine. And probably most importantly, and what's interesting about him, he was a U.S. Navy flight surgeon, helicopter anti-submarine squadron, and the HLS 37, which there's a picture of his helicopter. So one, thank you for your service. And here is his family with two beautiful boys.
Thanks so much, Stan. It's a pleasure to take part in this series. I've had a chance to catch several of these, and it's just a fantastic service that you are putting on, along with all the speakers and Nancy in the background. It's been great, so really appreciate it. And I want to thank my two previous speakers. Those were fantastic talks. I guess I don't need to worry about Stan showing any videos of me dunking a basketball, though, like Kelichi. So in any case, well, I'm going to be talking about something that's the previous two speakers showed this great, compelling data, and I've got maybe a little bit more difficult task tonight to convince you about the role of orthobiologics in the treatment of hamstring injuries. So we're going to be talking about several orthobiologics, but focusing on platelet-rich plasma, which by far and away has the most evidence, virtually all of the evidence at this point when it comes to orthobiologics. And then I understand, in talking with Stan, that we have a majority of attendees are athletic trainers and physical therapists, and people have varying backgrounds when it comes to orthobiologics. So I'm going to just share a little bit about those, just so we're kind of start on the same level before we dig into the evidence out there. I don't have anything to disclose other than, well, everything I'm going to be talking about is off-label, so makes that easy. So what if I told you that we have a reliable and rapidly effective treatment for hamstring injuries? And it's not CBD oil, it's not hydroxychloroquine, and it's probably not orthobiologics either, but that question is still to be determined a bit. So that's what we're going to talk about here. I won't end it right there, but that's sort of the punchline. But this is definitely something that deserves more research, and I think we need to have a better understanding of, because obviously a lot of folks, especially at higher levels of athletics, are using orthobiologics. This was a study from 2018 with Chris Ahmad and colleagues that they basically surveyed pro and college team physicians and found that a large percentage were using PRP, and in particular, you can see this from the study that they listed hamstring injuries as the most common injury that they used or that they treated with PRP, and most were using at least 3 injections, and that'll come into play later when we look at some of the data. But the conclusion of the study was that these physicians are using PRP really with a lack of consensus regarding some of the, whether it's effective and a lot of the different variables involved. So definitely warrants further study and I think analysis of what's out there. I want to just go back for a second and talk about what exactly regenerative medicine is. So people use a lot of terminology in this field, and they use the term regenerative medicine, which sometimes doesn't necessarily accurately represent what the data tells us. Certainly with soft tissue conditions, that is definitely the goal. We're finding actually that some of the best evidence is the use of these in arthritis and joint conditions where we may not actually see true regeneration, but it certainly seems to be effective for pain relief. But traditionally, there's 3 components that we think of. We think of having some cells, a scaffold, and growth factors. And so I sometimes talk to patients about the fact that, if you're a farmer, you need all 3 of these components to have a successful outcome. You need to have the seeds, which are kind of like the cells. You need to have a place for the seeds to grow on, and that might be your biomaterial scaffold. And then you need to have some growth factors, maybe some fertilizer to stimulate this process. And so this is a very big business. I mean, they don't have to look far to find a stem cell clinic or get on the web and just, do a search for stem cells and see what comes up. And so a variety of different fields, many outside of orthopedics. Some of them you probably don't want to know about with these latter two, but certainly orthopedics and musculoskeletal medicine is the most popular and probably the biggest business when it comes to these type of substances. I prefer the term orthobiologics because I think it's just more accurate when talking to patients as far as representing what it is and maybe not falsely representing what they're doing. Now, with regard to orthobiologics, it's really, I think, just another name for regenerative medicine and musculoskeletal medicine. But, we have a variety of goals with these procedures. They can be either autologous or allogeneic, and most of the ones we'll talk about today are autologous. You should just have an understanding that there is a lot of regulation from the FDA with regards to these products. And so that's why, you hear about some athletes going to other countries because they think that, they can potentially get the good stuff overseas where it may not be as regulated. But in the United States, the FDA basically limits how much we can manipulate these products and whether or not they're used in a certain area or in a similar area of the body or with a similar function. And so if we start venturing outside of those ways of manipulating things, then the FDA considers that a new drug, and then it falls under a different category of regulation that requires us to do safety and efficacy studies, which that's what they do for pharmaceuticals. Requires years and many millions of dollars. So these biologics, if we stay within this minimally manipulated set of working with them, then we don't necessarily have to worry about as much regulation. And so there's a lot of confusing nomenclature. People throw around the term stem cells. It's funny that the scientist Arnold Kaplan, who coined the term mesenchymal stem cells back in '91, actually has been campaigning for people to not use that term in recent years. If any of you have seen him speak, because we've learned more about these things, and we know that what initially may have been shown in vitro in a petri dish doesn't necessarily represent what happens in a living person. So there's a lot of, I guess, evidence at this point that we're not necessarily using these things to regenerate as much as to signal your body to do the healing. Now, why might we use orthobiologics for hamstring injuries or for muscle injuries in general? Well, I've just as a reminder from physiology class, your phases of healing with regard to muscle in particular. The thought is that we might be able to intervene in the second phase of repair and proliferation of using orthobiologics, things like PRP, to actually stimulate new cell formation and potentially reduce some of the fibrotic tissue. And so that happens, as you can see here. The repair phase is typically very soon, starting very soon within the first day or so, peaks during that first week, and then will slowly go down. So that's why you'll see a lot of these studies. The goal is to potentially treat the injury within that first week or even sooner. Okay, so what orthobiologics are available for us? So we have, I'm going to talk about 4 of them, and these just happen to be the most common that are FDA compliant. So these are available to us in the clinic. Platelet-rich plasma is what we're going to spend most of the time with today. And you can just think of this as a blood product where we've centrifuged it to remove some of the cells that we don't want. So in particular, most of the time we don't want the red blood cells, and we sometimes want white blood cells, sometimes not. That's a point of controversy, and you'll see in some of these studies. And the platelets are what we're trying to concentrate, because platelets are really just packets of growth factors. And these growth factors are what we think at this point are having the major effect on healing, pain relief, and some of the things we're trying to accomplish. They also attract stem cells to the area, and they modulate inflammation. So, you know, the contents within PRP, platelets have been shown to generally be anti-inflammatory and anabolic, whereas some of the other contents, certain types of white blood cells, such as neutrophils, tend to be more catabolic and more pro-inflammatory. And so depending on the condition that you're treating, you may want more or less of that. Again, that's you know, sort of the question of the hour right now. Now, we're sort of talking about PRP and variability, so you can potentially have what's called, people refer to as white blood cell poor or leukocyte poor or leukocyte rich PRP. So you generally are going to have, generally you're going to want more platelets, the better, but the issue is that with most of the commercial kits, the higher the platelets you're getting, also typically the higher the white blood cells. And so again, if you feel like the white blood cells are not worth those additional platelets, then you probably want to use a leukocyte poor product. And in general, that's been shown to be less inflammatory and more anti-inflammatory. Now, you may have a condition where you want to promote some inflammation, such as a chronic tendinopathy. The problem is most of the data out there is not reporting on you know, the details of the PRP used, and so that can make it difficult to interpret. Now, is PRP safe? Well, the good news is with PRP and the other products that we'll talk about, that these things seem to be very safe. There have been no serious side effects reported. It's very common for folks to have maybe a flare-up in pain and swelling for a few days, but other than that, pretty safe. Now, there are some concerns about cancer, particularly in a patient who currently has cancer, which obviously is not going to apply to most of our pro athletes, but that is something that's up for debate right now. Now, the issue with PRP is that there's so many variables that we don't know how to optimize at this point. So we don't know optimal composition for particular conditions. There are activators that you can or you can use or not use. When you're talking about soft tissue injuries like a tendon or a ligament, some people feel that it might be useful to use a needle to fenestrate the tissue, especially in the case of, say, a chronic tendinopathy, where the theory is that you're trying to actually create a controlled injury and sort of restart a healing process. So, you know, questions about needle size, how many fenestrations are optimal, and then how many injections? Do you do just one? Do you do multiple? What should that timing be? And, you know, how does PRP compare to other orthobiologics or even combined with other orthobiologics? So people are doing all kinds of things beyond what has been published at this point. Post-procedure rehab is another item that I think we can do a better job of defining, particularly with muscle and tendon recovery. So then that moves me to stem cells. And so that's the last time I'm going to use that term in this talk. You know, Arnold Kaplan, who started using the term mesenchymal stem cells, now likes the term medicinal signaling cells. So he could use the same acronym, but he thinks that better represents what these things are doing. So they are definitely more sophisticated than platelets. Platelets are, again, just dumping growth factors on contact with damaged tissue, whereas MSCs, you know, are able to interact with their environment, recognize the types of inflammation, and potentially respond in a more sophisticated way. And so how can we harvest MSCs for clinical use? Well, there's a couple tissues that are common. But the most common certainly is from bone marrow, and this is just a picture of how we might harvest that from the back of the pelvis here. And this is just under ultrasound guidance, the needle going into the pelvis and aspirating the bone marrow. And then we just concentrate it in a very with PRP. Another option is obtaining adipose tissue. So adipose has the potential advantage of having more of these cells per unit than bone marrow. But there's some other arguments that maybe those cells don't act as optimally in a musculoskeletal tissue as bone marrow. So that's kind of up for debate. But bone marrow, by far and away, is used more commonly. It should be recognized, though, that when we talk about bone marrow concentrate, this is not a, quote, stem cell injection. Yes, it contains some stem cells, but if you look here, those cells make up only about 0.001 to 0.01% of the cells in bone marrow concentrate. So really, I like to think of this as just a different type of biologic soup. And there are lots of things that might be beneficial in it, growth factors, different types of cells, and it's just a more cellular product than PRP, but otherwise contains many of similar type of things that could be beneficial. So we don't actually know that it's the stem cells or the MSCs that are beneficial here. Is it safe? There's 10-year outcome data for arthritis and other conditions that seems to be very safe. The bone marrow aspiration procedure complications are very, very low. There are concerns about doing it in the setting of cancer, but otherwise seems to be a really safe procedure. Lots of questions, though, about it. Again, we don't really know what the optimal way to harvest this is to maximize MSCs, and we don't really know whether the MSC portion really even matters at this point. And we need to find out all the other things that I mentioned with PRP as well, as far as number, timing, combinations with things like PRP, post-treatment rehab. I'm just briefly going to mention a couple other injections that you might hear about. So there are different types. We talked about adipose or fat-derived injections. And right now, we actually have some clinical trials going on at Mayo in osteoarthritis, hip and knee osteoarthritis, using culture-expanded adipose-derived MSCs. So these are MSCs that we have removed from fat and then grown in a lab and multiplied many, many times, and then we are coming back and injecting them. This is something that's only okay under FDA trials at this point. So this would not be something that you would just do in the clinic, but this is a true stem cell treatment. Whereas another option here is the stromal vascular fraction. Now this is a treatment where it's a same-day procedure where you chemically or enzymatically remove the cells from the fat and then inject this little pellet of cells called SVF. And the problem here is the FDA considers it more than minimal manipulation. So while you might see some clinics out there doing this, this is something that's probably going to be shut down as the FDA starts enforcing things more later this year. So that brings me to MFAT, microfragmented adipose. So MFAT is the one type of adipose product that is okay for office-based procedures at this point. And basically, instead of enzymatically releasing cells, we're mechanically grinding these up and then injecting them. So it sounds sort of crude, but there are kits that make this pretty easy. And the big question is, does it work? Well, it's been shown to actually work pretty well for osteoarthritis pain, at least on the order of BMAC and PRP. But again, for the things we're talking about today, really, I know people are using it, but just no data out there. And then finally, we'll just mention placenta-derived injections. So this is where we move from autologous to allogeneic. So again, this is no longer coming from the patient, but from somebody else. And this is basically, there are companies out there that take amniotic fluid or placental tissue and then dehydrate it and make it, a product that you can draw up out of a vial and inject. And these things are often falsely advertised as stem cell treatments. They've been shown to not contain live stem cells, but they do contain some growth factors that in some small studies have shown to improve pain and function in things like chronic tendinopathy and arthritis. But at this point, we don't have any data for hamstring injuries. Okay, so that's sort of our quick overview on different orthobiologics. So now with regard to hamstring injuries, I think it's important to think about this spectrum of injuries we talked about. So, Kelichi talked about these, acute proximal hamstring tears that he operates on. And, we're not talking about using these to treat, complete proximal hamstring tear. I think that, when we really think about where these things might be useful, we have to think of patient selection here. So if we go down here and we think about different injuries, this is an example of a low grade, probably mild grade 2 hamstring injury on ultrasound. And what we're seeing are the muscle fibers, and then we see this area of discontinuity. But it's not, there's still lots of fibers running through here. This is not a grade 3 type injury. So this might be a potential candidate that you'd go for. Whereas, this is, I didn't have a grade 3 hamstring to show you, but this would be a myotendinous injury of the gastrocnemius, where you can see this is an ultrasound image with a big hematoma. You can see the fibers totally pulled away from the aponeurosis. So not that this would necessarily be an operative injury in the gastroc, but in the hamstring, maybe. Now, if we think about proximal hamstring tendinopathy, this is an MRI axial image showing the origin off of the ischial tuberosity. And this would be an example of tendinopathy, maybe some low-grade partial undersurface tearing. This might be somebody that might be a good candidate as opposed to those, complete avulsive type injuries. Whereas in this would be a grade 3 tendon injury here. What we're looking at is distal semitendinosus avulsion, where you can kind of see this ball of tissue that used to be attached in the anterior tibia, but now this is balled up in the back of the thigh. And so obviously injecting PRP or something into this is not going to make this tendon, go back to the bone where it was attached. So I think right there, we can just with logic probably narrow this down to acute muscle injuries that are probably in our grade 1 to 2 category. When it comes to tendons, we're really thinking more about those chronic tendinopathies, certainly at the proximal level, conjoined or semimembranosus, potentially distal. We've done some distal biceps femoris injections, but we're really talking about low grade, not really these high grade hanging on a thread or complete type injuries. All right, so with that, I'm going to dig into some of the literature, which there's not a whole lot, but I want you guys to understand what's out there. So starting with PRP, in fact, everything we're going to talk about is PRP because that's the only biologic that's really been studied for hamstring injuries. We're going to start talking about acute muscle and myotendinous injuries. So back in 2013, Rettig published this case control study, basically had 10 NFL players, 5 receiving leukocyte-rich PRP, and 5 with just the usual rehab. And he reported that they had a single injection, didn't have any complications, and you can see the outcome was return to play. PRP group came back in on average 20 days versus 17 for the control group. So this really wasn't very convincing for the use of PRP. Then Hamid came out with this randomized controlled trial in 2014 that kind of got people's attention. And now these weren't baseball players, but this was these were track and soccer athletes. I think this was in Malaysia that had acute hamstring injuries. These were grade 2 injuries, some new, some recurrent, and a variety of different muscles. He also used a leukocyte-rich PRP, the same one that Rettig did, and did this with typical rehab versus usual rehab, only this was a randomized controlled study. And again, just one injection shortly after the injury. And you can see here, return to play, 27 days for the PRP group versus 43 for control. So this all of a sudden got people's attention. Now, I'll just sort of point out that, okay, this is a grade 2 injury. What are we expecting for return to play for a grade 2 injury? Well, I mean, I think what's published out there is probably closer to 27 than 43. So to me, the first thing I thought here was this seemed like it was a little bit on the high side for the control group, and this wasn't really dramatically different from what had been published out there for conservative treatment for PRP. So then about the same time, there was another randomized controlled trial that Ruring published. This was actually in the New England Journal of Medicine, so it had a really wide visibility. And this was a double-blind, randomized controlled, actually placebo-controlled trial, multi-center, really, actually, I think probably about the most well-done study that I'm going to talk about today. They took 80 competitive and recreational athletes with acute hamstring muscle and myotendinous injuries. Didn't get into what the grade was, but you know, I reading between the lines, it sounds like they were probably grade 1, grade 2. And difference here, use leukocyte poor PRP. So use this product that some of you might be familiar with, Arthrex ACP, which, you know, really is hardly PRP. It's plasma that has maybe 2 times, if you're lucky, platelets. So it's kind of like plasma with all the cells taken out of it. Not to say that's a bad thing, but it's a lot different from some of the other products that are out there that are giving you a lot more platelets, but also a lot more cells. And they used this with traditional rehab versus actually a group that received normal saline with rehab. And what was interesting here is they also did 2 injections, which was different from the previous studies. And you can see the results here. So again, no complications. PRP group comes back in 42 days. Saline group comes back in 42 days. So, you know, not a really well done study that, you know, multiple injections, used a different type of PRP, and then, you know, just really no difference at all. Even with the recurrence of injury at 6 months, identical. So this, to me, you know, came out about the same time as the Hamid study. I thought this was a lot better study. I wasn't really convinced at this point. And this just shows some of the data points from that study. It was, you know, pretty convincing, PRP versus the saline as far as return to play. So then a couple other studies have kind of trickled out since then. So Giotto, this was out in 2015. So what made this study unique is that he actually looked at grade 3 injuries. So this is the only study out there that I'm aware of where they looked at these really severe muscle and myotendinous injuries. And so these were competitive athletes. This was a prospective cohort study, not randomized. And they basically looked at PRP. Not sure what type of PRP, I'm not familiar. I think this study was maybe done in, I can't remember, somewhere in Europe, but I'm not sure what type of PRP this is, but did it with rehab, traditional rehab versus just a control group of regular rehab. And you can see no difference here in the return to play, 51 days versus 53 days, which, you know, this is probably not too bad for a grade 3 injury for either group, but didn't seem to make a difference. So then we had Hamilton's group came out with a randomized controlled trial here, a randomized trial where they had 3 arms. And this was, what made this study unique is that, I mean, first of all, it was a randomized trial, which is rare in this field. But what they did was they took a leukocyte-rich PRP, so one that had been used in several other studies, and they compared it with what's called platelet-poor plasma. So when you make PRP, part of this process is separating different layers in a centrifuge. And when you remove the first layer, it's called platelet poor plasma. So it's basically, you've got the red blood cell layer, that's the most dense layer. You've got the buffy coat with the white blood cells and a lot of the platelets. And then you've got the rest of the plasma that is this platelet poor plasma. And so platelet poor plasma, even though it certainly doesn't have any cells in it and, minimal platelets, but it does contain a lot of potentially beneficial growth factors. And people have talked about whether this might be beneficial for use in treating injuries. And so it was interesting. They used leukocyte-rich PRP versus platelet poor plasma versus a controlled rehab group. And did the usual injection within 5 days, no ultrasound guidance, but these were, presumably pretty lean athletes. And you can see the return to play here. PRP group, 21 days on average. Platelet poor plasma, 27 days, and control group, 25 days. Now, these were not statistically significant differences. So hard to say, these probably aren't meaningful differences between the groups. And the takeaway here was that, neither PRP nor PPP was useful. And so, I like this study because it kind of gives me an idea about what a head-to-head leukocyte-rich versus leukocyte-poor might look like. Because although PPP doesn't have a lot of platelets in it, it does have some. And frankly, this is, your typical Arthrex ACP is more similar to this than this. So, to me, this kind of gives us a little peek at what a leukocyte-rich versus leukocyte-poor study might look like. All right, so getting in the home stretch here. So our next study we're going to look at is published in 2016, and what made this study unique was that they looked at pro soccer players. So really, these are really high-level athletes. Again, grade 2 injuries, and they did multiple injections with these folks, and they did it based on how bad the injury was. So a grade 2A injury, so kind of that milder grade 2, received 2 injections, whereas the more severe grade 2s got 3 injections. And you can see what they came away with. Again, they didn't have a comparative group, but the return to play was about 37 days. So certainly not anything miraculous for your typical grade 2 injuries. They had 3 recurrences, kind of typical rate of recurrence. Interestingly, they looked at follow-up MRIs. These were pro athletes. They were getting MRIs right and left, and they had follow-up MRIs that showed really incredible healing, and they showed some diagrams in the paper that were just incredible. Like you couldn't see anything left after several months. So didn't help them get back to play sooner, but you wonder if maybe they've got better tissue there. So it's hard to know what that means. Now, this one, a lot of people have been talking about, Dr. Bradley's study out of Pittsburgh here. So really interesting, retrospective case control study. So on the positive side, we've got high-level athletes. These are, NFL players and grade 2 injuries. So kind of right in the sort of injury that we'd be interested in looking at. He used leukocyte-poor PRP. So again, this ACP that has been used in some of the other studies that we talked about. So this is, again, kind of, really mild or minimal platelets, but really no other white blood cells. So definitely very leukocyte-poor. And compared with just in a case control manner, compared with other athletes that were just doing usual rehab. And interestingly, he kind of has this protocol where he would potentially do a second or a third injection depending on how athletes were doing. So if their symptoms were improving, or if they weren't improving, presumably, or they had persistent tenderness or didn't do well with the Planck test, he might do another one. So, you can see there were some athletes that got multiple injections in the study. And what was the outcome? Well, our return to play mean days out was 22.5 days for the PRP group and 25.7 days for the control group. So, this was not statistically significant, this difference. The number of games that they missed, though, the PRP group missed 1.3 games versus 2.9 games in the control group. was statistically significant. So what was the title of the study? I mean, the title, I don't have it right in front of me, but it basically said that PRP shortens the return to play time for hamstring injuries. So I thought it was maybe, you know, a little bit overstating what they found, especially just with the, you know, the retrospective case control nature of the study. But it is what it is. It was in a pro population, and it's tough to do randomized trials in that group. And just for perspective, I wanted to show you guys, you know, blast from the past here, a study back in 2000 that looked at cortisone injections. So my gosh, who is doing cortisone injections for hamstring injuries these days? Well, at least for muscle injuries. We don't hear about people doing that much anymore, but at that time, he did a very similar type thing, retrospective case series, 58 NFL players, and injected cortisone with anesthetic within 72 hours. And what were the outcomes? Well, no complications, just like PRP. Return to play, 7.6 days. So, boy, that's a little faster than 22 and a half. So, you know, and we worry about what might happen, and, you know, who knows what happened to these guys, but at least during the duration of the study, he didn't find any functional strength deficits and didn't see any recurrent injuries. So, you know, just kind of, it lets you know that when you start looking at things like case series and retrospective studies, you know, that are non-comparative, you just have to interpret them appropriately, I think. So Stan, I'm not sure how much time I have left, but I was just going to show a couple tendinopathy studies, but you can flag me down if we're over. But I wanted to just show you a couple studies out there on proximal hamstring tendinopathy. So the one difference here with a tendinopathy treatment and PRP is, I think you really have to consider what you're doing with the needle. So this is just an ultrasound image of a PRP treatment of a proximal hamstring tendon. This is the ischial tuberosity. Here's the tendon complex right here. And you can kind of see the needle just coming in and out of view and sort of distributing the PRP through the damaged areas of the tendon. So, you know, this is no longer an acute injury. We're talking about somebody that's got this chronic tendonitis, maybe some low-grade partial tearing, and, you know, it's just not healing. So your body's kind of forgotten about this thing. And how do we jumpstart a new healing process? So that's where I think the question of this needle tenotomy part, and it's been very well established in other parts of the body, say for tennis elbow, that the needle tenotomy is by itself is very effective treatment. So the question is, you know, what do you do with that aspect of things? And you can see just in the couple studies that are out there right now for proximal hamstring tendinopathy, this is just a retrospective case series looking at leukocyte-rich PRP. They used a 22 gauge needle. Really didn't mention much of a tenotomy at all, but these were elite runners. So now we're kind of moving more from sort of, you know, sprinting type athletes that are getting the muscle injuries to more of the chronic hamstring tendinopathy in runners. And they reported really pretty excellent results. But you can see this was over 4.5 months. And they were all able to return to running. So, you know, kind of impressive, but pretty, you know, low numbers case series. Another study, this one using leukocyte poor PRP, again, similar type population, a lot of runners, and they didn't really mention any needle tenotomy, but these are 22 gauge needle. Follow-up 6 months, they had some reasonably good improvements in the VAS pain scores. And then finally, we have a double-blind randomized control trial, the only one I'm aware of for proximal hamstring tendinopathy, and they compared whole blood, which is also a treatment that we didn't talk about today that some people are using, versus leukocyte-rich PRP. And they did do a needle tenotomy, said for 1 minute needling the tendon, and ultimately, when they looked at their outcomes at 6 months, the results were just kind of so-so, and there was no difference between the groups. So you can see that, I'll show you this little graph here. This was one of the outcomes they looked at. The hip outcome score, and they went from about a 65-70 to maybe an 80. So, you know, not a huge improvement. It was enough to be statistically significant, but there was no difference between the groups. So a lot of stuff, guys, but I just want to summarize by saying that PRP is certainly a safe treatment option for hamstring injuries. And I think for acute grade 1 to 2 muscle and myotendinous injuries, really we have to admit that there's just not strong evidence that it speeds return to play. Now, having said that, it's a very safe thing to do, and there's certainly some athletes out there that will benefit. We just don't know at this point who that's going to be, but you know, through more study, hopefully we'll figure that out. Now, with chronic proximal hamstring tendinopathy, we have pretty weak evidence for PRP benefiting in the case of tendinosis or low-grade tendinopathy. You have to keep in mind this is going to be a long recovery, but it does work for some patients. And I think there is probably a role for needle tenotomy that needs to be borne out in more studies. And finally, we need to have an understanding of what the optimal PRP contents are with regard to white blood cells, different types of white blood cells, amount of platelets, growth factors, et cetera. And, you know, all these other factors, multiple injections, you know, types of rehab. And then finally, you know, we need some data. We need to start getting some data on some of these other orthobiologics, bone marrow concentrate, MFAT, placental products, and potentially, you know, others that come out. So a lot of stuff. I'm happy to answer questions here. Thanks, guys.
Great. Thank you. Thank you. We'll get all the speakers back on. A lot of good questions going on. So you get everybody back on. Maybe. There we go. Can we unmute them, Nancy? Okay, great. Okay, we've got a ton of questions. So we're gonna go through those. One of the things I'm gonna ask right away that I think I've talked to Holly and Kelichi on is this concept of, in both your studies, you showed that the left leg had more hamstrings than the right hamstring. And I presented this study at ASMI in January, and a ton of people came up and asked me, why is it left versus right? I think in Holly's study, it wasn't statistically significant, but some other studies it was. In ours, we had not statistical significance, but definitely a trend toward more left than right. Now, the PRI people who are in the audience are saying body's asymmetry, and maybe there's a reason for this. Holly, you went into a little bit of not just left versus right, but left hitting, right throwing, that type of thing. Can you maybe elaborate on that?
Sure. Yeah. Hats off to our biostatistician that really helped us break that down. It was just an interesting trend. We saw like left-handed hitters with a higher propensity, if you will, to have hamstring injury. And then when we broke that down in terms of stratification of side, we didn't see a statistical difference in terms of right or left, just in terms of overall injury risk. But when you think about it, if you think in terms, you know, in sort of the PRI philosophy, if we think about muscle imbalance, if you will, and then when we look in some of the normative values that we established in our MLS athletes, is that we saw a real interesting differential, if you will, between sagittal plane kinematics and strength. So I think that's what's really interesting about teasing this all apart on an individual basis and really knowing, hey, if we've got an individual at risk, can we unravel some of these imbalances and perhaps be protective going forward? It may play some role in terms of, we've seen anterior pelvic tilt described in the literature. Are there some risk factors associated with that? If we've got an altered length tension relationship occurring because of that, and that's a little bit of the chicken or the egg phenomenon, but you could argue, well, with an increased length tension relationship in the hamstring musculature with an anterior pelvic tilt, does that put them at risk on a reach or a deceleration because they're functioning on altered length? Be interested to see Kelechi's thought on that.
Yeah, so I kind of have the same kind of thoughts. I think that there is an asymmetry in the body, similar with the upper arm. I think there's a dominant leg, and most of the times that's the left leg. And so when you have some of those muscular imbalances, like the quadriceps, the glutes, those can overpower each other. And kind of what I found in that study is when you have a quadriceps to hamstring ratio less than 0.6, that's when you have increased risk of hamstring injuries.
Good. Nancy, why don't you grab a couple questions out?
Okay. With the first presentation, would you potentially look to avoid NSAIDs as part of the treatment to allow for the inflammatory process of healing rather than delay it and potentially create a more toxic environment for healing?
Yeah, I guess that depends on what kind of injury it is. Because like I talked about, that scar that forms, we don't want that scar. And I think that's some of the impetus to do PRP, to kind of decrease that scar formation and give it a more natural tendon, so you don't get that increased stress right next to the scar tissue.
Jacob, on that particular question in regards to PRP, leukocyte poor and leukocyte rich, the leukocyte rich has a tendency to create an inflammatory reaction. And what I think the person's asking is an inflammatory reaction part of the healing process, or should it be avoided? So PRP might, depending on the PRP concoction, could be inflammatory.
Yeah, it's a good question. I think if we're talking about an acute injury, really for any of these injuries, acute or chronic, we do want some inflammation. The question is always how much, but I think you certainly don't want to squelch it. And I personally don't like patients to use NSAIDs, whether we're talking about whether we're using orthobiologics or not for an acute phase in an injury. So certainly not if we're using orthobiologics. I have patients hold off for at least a week before to let it run out of their system, and potentially anywhere, well, with a soft tissue injury, at least 4 weeks after.
So Kelichi, do you, I don't know if I got your answer, would you go to anti-inflammatories right away after a grade 1 hamstring injury?
So not a mid-substance. So if we're talking about a proximal rupture, then I think it's okay. If we're talking about a mid-substance strain, those are the kind of injuries, just like Jacob talked about, that we wouldn't use NSAIDs in.
You would, okay. Another question, Nancy?
Okay. Has there been any thoughts or considerations when tracking the baseball-specific injuries that occurred while running to first base to break those out, to subcategorize them into like 2 separate areas, the mid-stride running down the baseline versus when the player is actually lunging onto first base with the hip inflection and in some range of flexion, where there's a more eccentric load compared to the true sprinting injury?
Right. Yeah, that's a really good question. I think those are 2 kind of separate injuries. So when they're hitting the base and doing that eccentric contraction, like I talked about in my slides, is when you're having that proximal rupture away from the ischial tuberosity. When you're in mid-sprint or at the beginning of the sprint, that's when you're having those mid-substance and those partial tears. And those are completely different injuries.
Yeah, the problem with our particular study is we used HITS data. HITS data is anybody who has to put those injuries in every day recognizes that there's only so many selections, and when they talk about running to first base, they don't break down out of the box halfway through or at the end. It's just running to first base. So the classifications aren't detailed enough to actually get into that thing. What you all talk about is that guy shouldn't jump at the first base to try to get there quicker, that he'll have an injury there. We don't have that data in the HIT system. Holly, anything on your side?
Yeah, I think it's interesting, and it would be a really good idea to go back, because most of these happen in the game situation. You could go back and do a video analysis. I think it's a great suggestion and a good study going forward that I'd be happy to collaborate on, because I think it is very different. You know, when we look in terms of stratifying, you can kind of minimize it and say, oh yeah, 60-70% are running to first base. Well, they're very different injuries, right, depending on where they occur.
Yeah, it's interesting. We have tried to do some of the video analysis. So we did this on catcher's concussions, and I looked at video for about 6 hours and got maybe 3, concussions. So it's super time consuming on that. Yeah. Nancy, can you get orthobiologic question in there?
Yes. Okay. There's a bunch here. Let's go with. Sorry.
Okay, I got one real quick.
Okay, go for it.
The Kobe Bryant situation in Germany. You talked a little bit, Jake, about the fact that in some countries the rules are different than the FDA in the United States. Can you address the Kobe Bryant situation and how they may have changed the molecular structure of that PRP injection or whatever they gave him years ago?
Sure. I'm not sure I know the details on Kobe's situation, but there are some products that people that are available in Europe and other countries that people are using that are trying that I don't really think we have any good data to say they're better than PRP, but what they might do are do things to say remove the growth factors from things like platelets or other cells and then inject those directly. People have been excited about these things called exosomes that are basically it's we talked about mesenchymal stem cells secreting growth factors and secreting things to activate healing processes. So these secretions can be packaged as something called an exosome that is popular right now. There's really just no safety data. There's just nothing out there. So it's hard to recommend those things. And I think, there's just an attraction that if it's not available, that must mean that it's the good stuff. But I think that's really just not the case right now.
Okay. I think in the US, the FDA is really strict on these biological products, and they like what we call minimally manipulated products. Mm-hmm. And so anything that requires manipulating it, once they take it out, has a really rigorous process to get approved, whereas overseas, it's not as stringent.
Yeah, I mean, I think that the one thing that, I mentioned that there are clinical trials right now using culture expanded stem cells. So that would be something that I know a lot of patients go overseas down in the Caribbean and so on to have access to an actual purified stem cell treatment where you have the cells harvested and then the company grows them in a lab maybe many times and then you get them injected. So for example, with a BMAC injection, the typical BMAC injection that people get, you might get tens of thousands of stem cells, whereas with one of these treatments, you might have 50 million. Like for example, in the clinical trials we're doing, we have 50 or 100 million. So just orders of magnitude different, and again, it's an isolated cell treatment as opposed to the soup of different growth factors and things that are in BMAC or PRP.
Nancy?
We got a couple of questions on what role does the adductor longus play in hamstring health?
Anyone want to take that?
Yeah, take that, Holly.
Okay, sure. Well, we have seen some correlation between AB to adductor ratio issues and hamstring injury risk. The nice thing with the study we did in MLS, because the numbers were so high, we were able to do a good regression analysis and sort of identify risk in those. And what was really interesting is the raw data in and of themselves of isolated muscle groups wasn't nearly as important as looking at the strength ratios. And we found that ostensibly, if we've got some weakness in the adductor, that again, to kind of back up to our that previous question, that there may be some role in underlying pelvic stability or alignment, if you will, and kind of use that term loosely. But that if the adductor is a little bit weaker, ostensibly we may be in a little bit excessive anterior tilt, and there may be some alignment from a pelvic standpoint, or perhaps even a femoral internal rotation perspective that may put the biceps femoris at a little bit of increased risk. So yeah, I think the jury's still out, and I think it's something we want to investigate further, but it's definitely something we saw some trend and minimal significance in the soccer data.
Mm-hmm. Okay. One of the things that we talked about on the hamstring studies was the number of injuries by position. We calculated on our study, Kelichi, maybe you can talk about this, of how we decided that pitchers had the highest injury rate. We didn't base that on pure percentages or pure numbers. Do you want to address that?
Right. So what we found is that originally the numbers show that the infielder position had higher numbers, but we know there are more positions out there for the infield. So we had to divide that number down as there's only one pitcher, and that's when we found that the pitchers had the higher incidence of injuries.
Yeah, this is important. We've done this on catchers as well. Catchers, when you look at gross number of injuries, but when you actually assume that a catcher is 1/9 of the field, where outfielders are 3/9, and you calculate it and be able to do it that way, you see a much different thing, especially in catchers. But in this particular study, pitchers were more, Holly, in your studies, the pitchers were not a higher rate based on percentage of injuries by position. Is that correct?
Yeah, that is correct. We only found significance with the pitchers, but overall, to your point, we didn't change the denominator based on whether outfield or infield, because ostensibly they represent a higher percentage of the field. So the only statistical significance we found was within pitchers.
Yes. So that's important to note when you read these studies, when you actually have to dig into the literature. Some people say, well, pitchers don't get that many injuries. They're not running the bases. But that's really not the case, because of when you normalize the data based on positions on the field, you get a different number. So that's important. To Jake's question for Jake is, in regards to PRP, the whole idea of PRP is to increase the percentage of platelets in an area, so that they end up, I'm gonna butcher this, but break open and growth factors are released to help the healing process. I've read some articles that talk about the increased number of platelets by PRP injections, and it's not all that impressive as far as an increase of maybe, instead of the normal amount of platelets is 1, it's about 1.5%. There's not a huge number of platelets, even though you're trying to segregate them and put them in one place. Can you address that?
Absolutely. I mean, there have been a few studies that have just done comparisons of different commercial kits out there. And of course, there are some people that make their own PRP as well. So, but in general, with the techniques that are available to us now, you can't have your cake and eat it too. You can't, there's not a great way to reliably make a high PRP product that does not also contain a significant amount of white blood cells. Now, the interesting thing is that there are devices out there where you can adjust, make adjustments, and you can get a PRP that's very high, say 10 to 20 times normal platelet concentration, and very low in red blood cells, low in neutrophils, but very high in lymphocytes and high in monocytes. Now, is that good or bad? I mean, I think at this point, we think probably when we talk about leukocyte rich and the catabolic effects of that, we're probably talking mostly about the neutrophils, or at least that's what I think, from a theoretical standpoint. And so what are those lymphocytes doing? Are they along for the ride? And it really, I think we just have to be more specific about what we're talking about. So what we're really talking about is this is a neutrophil rich or neutrophil poor PRP. With regards to some of the products out there, I mean, the reality is that some of the most popular products out there have also been in a lot of the studies. And while I didn't talk about a lot of successful studies today, there are other conditions like osteoarthritis where, there doesn't seem to be a huge difference between some of these products that barely concentrate platelets and some that have higher levels. And people really haven't been able to show convincing differences between leukocyte rich and leukocyte poor with regards to efficacy when we're talking about whether it's tendinopathy, whether it's the muscle injury studies I showed today, or even osteoarthritis. There's still some question about that. So I don't know.
Holly, in your study that showed significant decreases with compliance of the program, one of the things that I look at a lot of epidemiology in pro baseball, and what we've seen over the years actually is good news in the fact that a lot of these injuries are leveling off. They're not decreasing, but they're not increasing. Hamstrings, along with minor league UCL injuries, are increasing. You showed with one professional teams, and the Royals showed with another one, that you can decrease these injuries. So tell me why we're seeing so many increases in hamstring injury. Is it the old adage of whatever is said and done, more is said than done? Is that the issue on compliance? And we think that all these baseball teams are doing this. I think we ran a poll on it, didn't we, Nancy, on how many people were doing eccentric Nordic type hamstring programs. Why aren't we seeing a reduction in hamstrings? We're seeing a significant increase.
Yeah, it's quite frankly, the $1 million question. And to be fair to baseball, it's sort of ubiquitous with many sports. If you look at the UEFA data published by Young Extrand, and looking at, we have such compelling data in soccer and in European soccer, and it's like these programs are not utilized. We have the same phenomenon happening on the ACL prevention side. So I think kind of like dabbled with the last couple of slides, looking at the real nature of compliance. And I think Alex Donaldson and Caroline Finch, these researchers that are really delving into sort of the psychological and the sort of the psychosomatic sides of like why we make the decisions we do on the behavioral psychological side of like whether we adopt these new philosophies or not. I think we did an interesting coaching survey monkey, and before we did this intervention in Major League Soccer, and basically everyone was on board, excited. Yeah, we have a big issue with hamstrings. We got over 100% response rate. And when it teetered down, like 67%, when the question was posed, are you interested in being involved with an RCT and would you be involved? Everyone, for the most part, was saying yes. 70% of the coaches and GMs said yes. And then when it came down to, the actual intervention, the buy-in, we got one team. And then when we even presented that data, like at the national conference the following January, it was like, look, we got this one team and we had compelling data. I think it's complicated. We look at it, and I think it's different based on the intervention age group. So the cohort on the youth side, it's different than it is on the professional side. On the professional side, we have a lot of philosophies we need to engender. Like I said, we're not going to come off as dictatorial to strength and conditioning or ATCs, PT side. We need the team docs to buy in. General management, it might resonate like, hey, we're saving millions of dollars if we can prevent a couple of these happening and we keep that player available to you. I think it's really complicated. I think you could spend a whole couple of hours discussing just compliance in general.
Nancy, I know the poll is not done. Do you have any general numbers on number of teams that have said that they use a intervention hamstring program, or am I putting you on the spot?
Nope, I got it right here. Let's see, 72% said that Nordic hamstring exercises are part of their regular strength program, and 27% said 1 time per week, 40% 2 times per week, and 5% 3 times per week.
One quick thing, I think what was really compelling with the Kansas City data, it was like when you look at the intervention, their cutoff was 3.5 repetitions per week. And my estimation, that's a little low. We can kind of tease that out in the data, but I think also what's critical, we found the critical threshold to be about 2.38, so right around that 2 times per week mark. And if you're under that, you're not going to reap the benefit. So it really has to be fairly consistent. I think some of the turnoff, particularly with the eccentrics, is that they're difficult and they cause some soreness, and when do we intervene? When do we utilize them? We don't want to do them on game day. Do we use them in preseason? Will that maybe impact their performance short term? It's complicated, but I think the data is so, the prolificness of the data and the astounding statistical significance of it across sport, it's hard to argue with at this juncture.
Nancy, a couple more questions.
Okay. For Kelichi, and regarding the endoscopic hamstring repairs, what % of hamstring strength are you expected to regain compared to the uninvolved side?
Yeah, so I don't think the repair differs in terms of what we're actually doing. So I'd expect the same strength in an open repair as endoscopic, so that 90 to 100% strength afterwards.
Yeah, I think I was going to say this earlier and I got sidetracked, but if anyone's had an opportunity to see an open proximal hamstring repair, it is an ugly operation. It is a deep, dark, bloody hole, and endoscopic is a lot cleaner, I'll tell you that. So, yeah. And I would think the recovery would be a little easier, at least acutely.
Yeah, smaller incisions. It's a little more technically challenging, so a lot of people don't do it, but it's a nice procedure if you have the skill set.
Nancy?
I've been hearing good results about A2M injections. What are the similarities and differences, if any, to PRP injections?
That's a good question. So A2M is, a lot of people are excited about that. Really, so A2M is alpha-2 macroglobulin, and it's, I mentioned that PRP is sort of a biologic soup. Well, it's one of the many things that are in PRP, and people have been drawn to it because it seems to have a powerful anti-inflammatory effect in that it can basically lock on to some of these destructive cytokines that are in our tissues that, in particular in osteoarthritis, that's where I think a lot of people have been excited about it because it tends to lead to pretty quick pain relief. At least, again, not hardly any data out there. A lot of this is anecdote. I got to say, I really have not talked to anyone who has used it for acute muscle injury. Again, you want to have some degree of phagocytosis and, destructive sort of inflammatory processes happening to remove damaged tissue. So I think it's a little presumptive to think that, you would know, that that's the thing to do for muscle injuries. I mean, maybe you guys are aware of some data that I'm not, but I just, I'm not sure about for acute muscle injury. I guess I couldn't recommend it at this point, but I think osteoarthritis, I do think it's something that may be worth trying.
There was some talk on both of us in regards to hamstring injuries in baseball that occur at the early part of the season in April and May. I know, Holly, you talked about into the first half, into the game fatigue-wise. I wonder, just in a general way, since we're going into an abnormal season, we've seen that soft tissue injuries do happen more in April and May. We've seen it in obliques, we've seen it in hamstrings, we've seen it in other soft tissue injuries. There's a bunch of theories about why that is. Holly, you talked about temperature. In this next iteration of professional baseball, temperature will not be an issue. So it will be fascinating to see in the first month of this abbreviated season whether that holds true or whether it doesn't. And then we have abnormal off-season, spring training that stopped and started, all those kinds of things. What are your thoughts about soft tissue injuries in July, the first month of the season?
Yeah, unfortunately, like if we're going to look to, so the Bundesliga, for those of you that follow soccer, they just opened their season last weekend, and there were a very high incidence of soft tissue lesions during that first weekend. So they had over, I believe it was 8 hamstring injuries last weekend. Unfortunately, I think they may be a little higher than we would want them to be. And that's all predicated on, what were these athletes doing at home in terms of, you know, soccer's a little bit different in terms of like, how do you maintain match fitness within, you know, when you're self-isolating? It's a little difficult, but I think if we're going to look to other sports that are coming back, I think that injury rate, we may see an initial spike. I hope I'm wrong, you know, in terms of baseball, but I would be sort of, from a medical staff perspective, I would be prepared for that.
Kelichi?
Yeah, I think multiple risk factors kind of go into it. I think Holly was looking at temperature, the effect of temperature, but I also think that whenever athletes come back from off season, they're less, you know, flexible, they're less in condition. So I think no matter when the season is, there's probably going to be a spike at the initial season.
I think it's going to be fascinating. We know that a lot of people in the audience are calling their pro baseball players every day to find out what they're doing, how they're doing it. Of course, they can't see them most of the time on what's going on. There's different theories that go out there. One is, well, we've had more rest, therefore these guys have not broken down through spring training, which spring training is not an easy process. It's a 6-week haul. And whether or not that was a cause, or whether they were not in good condition to begin with going in, and the difference between the increase in competition from a spring training thing to an actual game, and whether that increase, that 5% increase, causes some of these soft tissue injuries. I think it's going to be fascinating, and I give to the people out there who are working with pro athletes, pro baseball players, you need to start thinking about collecting data and seeing exactly what happens, not just hits data, but your own people, and how you're segregating them, how you're training them, and what the injury rates are, because this is going to be hopefully the only season we have like this. I think it's going to be fascinating to see what the injury rate is in the first month compared to previous first months, and also the fact that we're going to go into November with the playoffs, and we're going to have a short off season. So what will happen in 2021? I think now's the time to start thinking about potential studies to evaluate that in a shortened season. So interesting things. Nancy, one more question and we'll call it a night.
All right. In these studies, what point after return to play did you find that the hamstring strains were recurring?
Yeah. So that wasn't a data point in the HITS data. That is a great question to kind of separate what time. Was it early? Was it late? Unfortunately, we're limited by the HITS data being retrospective, and we're able to see that.
Yeah, it's a good question, and we wish we could have had that. The HITS data is pretty rich, but it's not perfect. So, okay, great. Listen, thank you very much. I really appreciate the speakers. We're going to put a poll up here. We're going to leave the webinar going for about 5 minutes so you can finish that poll on everybody. Remember that after the poll is over, you should see a survey to take for your CEUs. If you don't see them or you don't do them now, you'll have 24 hours, you'll get an email that shows them, please do the surveys. That's how you get your CEUs. Again, thank you, and we'll see you next week when we're talking about the the hand, thumb, and wrist with Dr. Steve Shin. We've got a very interesting panel in regards to working with the hand. It'll be pretty good. So again, next Wednesday, hope to see you then. All right, good night.